satisfied with the state that the baby is in, then we explain the procedure to the mother and then carry out all the necessary examination that has to be done with both physical and then neurological assessment of the newborn. So with it, we know we have to do this to detect any abnormalities as early as possible, which may have any fatal effect on the baby. So it's very, very clear and very important for us to do that. And to prevent any deviation from the normal, to also know the progress of the child. So without wasting much time, we have a small tray here with a temperature already there, and receiver, and then cotton swabs with methylated spirit to take care of the cord. We know that now we use the chlorhexidine gel to dress the cord. And I know and believe that not every facility do have that. That's why I brought the methylated spirit too, because methylated spirit has been in the system for a while. So this is a new that Ministry of Health or Ghana Health Service has introduced into the system for us to use to take care of the cord. Okay. So before we carry this procedure out, hand washing, which I have done already, and I wear my disposable gloves, expose the baby or remove the clothing from the baby, and then examine the baby from head to toe. So it is, like I said, it's physical and then neurological. So with physical, we will see, and then neurologically, we will also see what comes into play. So we'll expose the baby, and then we give a glance look on the baby. Remove the dress of our baby, then together with it, we make sure that we don't expose our baby to the environment. Now remove the diaper too. So when the baby is exposed, I'll observe at a glance to see how this baby is faring, the cry, the color, the movement, the attitude, and the behavior of this baby will tell me that this baby is fine. So the examination starts from the head, the scalp, the sutures, the fontanelles. So we observe the scalp for any cuts, rashes, swelling like caput, Kefa hematoma, caput ocidum. Okay. So the caput is as a result of pressure applied to the fetus's head when on the journey coming. A little bit swelling and unilateral. The Kefa hematoma is bilateral, because this one doesn't cause a suture, the other one will cause a suture, and so you see both a size of the head with the swelling. But with caput, within 24 to 48 hours, it will dissolve. And with a Kefa, it may increase, and with sometimes may need some kind of incision before this baby is Fine. So you look at the frontal suture, the coronal suture, both left and right. Then the Bregman or anterior fontanel. If it accommodates one finger, it means that uh, the head is not enlarging or enlarged, which may be a sign of hydrocephalus. Then we have the sagittal suture moving down to the posterior fontanel and the lambdoidal suture. Then the occipital protuberance also readily visible. But there are no scars, there are no cuts, no rashes, and no swelling. So the head is fine for this baby. Now, because we don't want the baby to lose heat, when you finish with the head examination, we cover. So let me do this one. So when you finish with the head, you can also carry out a head circumference examination to make sure that then we move to the ears. So we look at the outer contours of the eye and the margin to the ear. So it's in line. If it is low set ear, then you have in mind trisomy 13, which is down, an abnormality which is figured by low set ears and broad eyes, flat nose, and then you see that. Then immediately it tells you that everything will refer the baby to. Now we open the eye, so we hold the upper eyelid and the lower eyelid downwards to see the color of the eye. If sometimes there may be black spots on it, or you may also realize that the eye has become yellow, the conjunctiva has become yellow. That tells you of physiological jaundice. Then you do the same to the other eye. Okay. Now, after everything, you touch the nasal septum. Look out for any swelling, enlargement, or flattening, or fracture over there. So if there is nothing there, you move on. Look at the nose. So you go this way and raise the little. You want to see the nostril, nasal polyps, or any growth in the nose. And then if the baby is breathing, if the nose doesn't flare up, it means that the breathing is normal. Sometimes when it flares, it tells you of difficulty breathing.
What? Hey, I told you. Hey, and now we playing football. Yeah. This is an issue. Why is that the buy football people? But the boy, the small children. Now I'm telling you.
Oh. Then, with the ear already done, there are no swelling, there are no ear discharges. And with the mouth, you touch the corner of the mouth, which is known as the rooting reflex. This baby will open the mouth and turn the head to where the stimulus is attached. And will open the mouth, start licking. So when the baby opens the mouth, you look through. Sometimes there is false teeth somewhere, which is the position of calcium. And then with the tongue, sometimes the babies may even have tongue tie. There may be a strip of membrane holding the tongue downwards. So when this baby cries, the tongue may not even be able to lift up. also some abnormality. But with this one, when the baby cries very loudly, it normally will tear off, so it's not good. Then we examine the neck for swelling, for lymphatic gland enlargement. There is nothing there. And we go to the chest. So we palpate, then touch the breast for swelling or enlargement. If there is nothing, we move on. We move on to the next. Then we try to bring the hands together for equality. Now these hands are equal. There's no softness anywhere. And we hold the humeral bone, press it in moderation, so that this baby, if there is any fracture or something, the baby will give a shout, a cry. And we count the fingers to make sure that I think there's no 6 or 7 extra. And the fingers too are not webbed together. So you look at the plantar creases. This is normal because this baby is a term baby. With preterms, you see that it has faint creases, plantar creases. And with Down syndrome, they have one, very long one. And so that tells you the difference. Then you hold this one too. There's no problem. Okay. And the same as this one, plantar creases are normal and there are no abnormalities. Don't want to expose this baby unduly. So, palpation of the abdomen. There are no tenderness around them. Let me take this time to check the heart rate. We check the heart sound, listen to the heart rate, and then the chest sound. And with the lower extremities to bring the legs together for equality. Then we also touch the legs for any abnormality. And then as well as this is the farmer creases and this one is the plantar creases. So we look at it. And then this one, the toes are webbed together. So there is an abnormality. There is an abnormality here. So this one, there is no. So this baby has the same problem with both feet. The 1, 2, 3, 4, they are all webbed together. This go together. So there is a congenital abnormality here, which we have to refer or transfer to the pediatric specialist to see. Now we do the Barlow sign, or we check for the hip or any dislocation. So it's like we flex the knees together, like this. Then you turn the hip bone inward and then you rotate. So it goes like flex, go this way, then you rotate. Go this way, then you rotate. If there is any problem over there, this baby will give a very sharp cry. And then it will tell you that there is a problem for this baby. But this baby did not give any cry out. So we take it as the baby doesn't have any hip dislocation or hip abnormality. Now, we come to the genitalia. This baby is a male. So you hold the scrotal sac for the testicles to see if they are in it. Then with the male, you hold the penis upwards, then you push the prepuce or the foreskin backwards to look at the where the meatus is, whether it is centrally situated or epispadia or hypospadia, where there is the opening, instead of being centrally situated, maybe upward or downward, which is a congenital malformation and becomes an abnormality which has to be addressed too. So with this baby, if this baby has that problem, the advice that we give to the mother is that she will not do circumcision, because if the doctors are going to repair that hole over there, that opening over there, they have to use the foreskin or the prepuce to do the repair. So if you do the circumcision, it means that they have to use skin grafting to do it. Sometimes it becomes very difficult for it to hold, because once they do it, they will pass the catheter all right, and they give some time, remove the catheter and see if the urine is flowing through the central lane of the meatus, where the doctors have dilated and opened it up. The urine may still pass through the other opening, which may cause the skin to give off. So it is a problem that we have to take care and address. If this baby were to be a female, I'll pat the labia majora, minora, see the vestibule, and then see the urethra, so that if there are any abnormalities coming up, you can easily see. Sometimes the labia majora may be very, very ambiguous with the clitoris standing out. You don't take care, you may think that the clitoris is a penis. And then you may, the mother may take it as this is a male. However, it may be a female, which is a hormonal challenge. So as early as possible, we refer this baby to the pediatrician, who will eventually take care and then carry out all the necessary things that is needed for this baby. So we'll go to the back and then test the baby's back for any abnormality over there that we see. So with this, we turn the back of this baby, and then we pass our hand from the neck to the lumbar region. So you pass it for You want to see if there are fractures, swellings, like spinal bifida. Some may be very occluded with just a point over there or hair growing around it. Or it could be bulging, which will be very, very clearly seen. And so it will tell you the baby has a problem. So after everything, we inform the mother and the relatives, then you refer this baby to the pediatric specialist. So with the back, if there is a fracture, this baby will cry. If there is a pain somewhere, this baby will still cry. So we take our time to do all these things so that this baby will be free. Then we can open the anus. You can ask the mother if this baby has meconium. If she says yes, it may be noted in the diaper. If she says no, the baby might have passed it during labor. The mother didn't see. So yours is to clean the area with cotton wool, then you observe. If you see the color of the meconium, it means that the anus is thickened. If you didn't see anything there, the woman says she hasn't seen that the baby has passed, then you use your little finger and then enter the anus to see if it can pass through the orifice a little. That tells you that this baby has. Or if she's a female and the woman will tell you that, oh, I've seen the baby pass the colon. It is our duty to still pass up. It could be a congenital abnormality, that is a genital fistula from birth. It is an abnormality or malformation which has become an abnormality at birth. So you look at all these things very critically before we write down our notes and then we send the baby to the pediatrician. Now, we have mentioned, we have about 6 reflexes that we can talk about. The routine reflex, which we did, touching the corner of the mouth. This baby will turn the head to search for the breast milk. And then we have the grasping reflex. So whilst we are examining, so you hold the baby's hand, then you put your hand in the baby's hand. This baby may grasp it. If the baby is able to grasp it, it means that the baby has no neurological problem with the upper limbs because you do it with the other hand also. So you hold it and this baby will be able to grasp you. If it's just hanging down without any effort to hold you, it may tell you that this baby may have Erb's palsy during delivery. That is a damage to the brachial nerves, which is affecting the upper limb. Then we have the moral reflex. The moral reflex is when you try to hold the baby up, like you want to throw the baby up a little, this baby will startle and then will become rigid at a point in time. Seriously afraid. That is what we call the moral reflex. Then the suck reflex is when you put the breast into the baby's mouth, the baby will be able to hold onto the breast and especially hold onto the black area, which is the areola plus the nipple. And this baby will be suckling. Then with the baby skin's reflex is when you give a stroke in the baby's feet, in the sole, that is in the sole of the feet, this baby will turn the whole feet upwards. It will be holding upwards. That tells you that there is strength or there is no neurological abnormality. So you do both right and then the left. Then it will tell you that this baby is healthy. Then we have the step. So you hold the baby up a little, like We want the baby to walk. So this baby may be turning this way. It's like, so it can be called step reflex, dance reflex, or walking reflex. So these are the reflexes we use to identify any neurological problem emanating from the baby. If you didn't see any of these things, it's telling us that this baby is healthy. He has no problem. And so you can give the baby to the mother and then you educate the mother. Then after everything, you check the length of the baby. So it's from the occiput downwards. So you place it down here and then, okay. And because I'm going to touch the cord, I remove my gloves and then I'll wash my hands and then wear a surgical glove. So when we clean the cord, we leave it exposed. Now we are going to educate the mother on cord care and how to keep herself from infecting the baby. After everything, I'll tell the woman how the baby is doing. Fine, she has no problem. And so before she goes home, education will give, because we are going to educate the mother on breastfeeding, observation of the baby for any abnormality that is seen, to report to the hospital as early as possible, and that she is not going to put any cow dung on the cord to prevent any cord infection that may lead to a lot of complications on the baby. So when everything is said and done, we'll send this baby to the mother, explain everything to her, and this baby will be put to breast to help the baby to suckle very well. And then we dress the baby to prevent heat loss. So when the baby loses weight, the heat to affect the baby's respiration and the entire body will be thrown into problems. So always have to keep this baby warm. So that after everything, tell the mother. I brought another cord clamp. If the cord was bleeding, I would have put the extra cord clamp to clamp below the previous one. But this one, the cord was not bleeding. So the cord clamp was not used. We also have everything I initially mentioned. That this one also is used to dress the cord. So if it is available at the facility, you use that one. If it's not available, the methylated spirit is still there. You can still use it. So whichever one is available, you can still use to make the cord clean and then prevent any cord infection. So the examination of the newborn is done at immediate subsequent. After discharge, she goes home 3 days. She will come at 72 hours. She will come to postnatal. The baby is still examined over there. The mother too is examined. 7 days, she will still come with the baby for examination. Then the 6th week. If she has any problem before the time given to the woman to come back for checkup, she can still come to the hospital and then complain so that the baby is taken care of together with the mother. So, in a nutshell, that is the definition of the newborn for I would like to emphasize on the matter of the gender of the baby or the sex of the baby. If we don't take care, sometimes the gender, especially if the cord that is cut is longer. When you hold the baby upwards like this to show the sex to the mother, the clamp, the cord may fall on the genitalia and it may cover the real or the true sex of the baby. So we always have to make sure if it is too long, even though it's long, you are showing to the mother, do well to raise the cord so that the mother will be sure of the sex that she's saying. The midwife who also did the delivery or the one who is showing the sex to the mother to be also sure of what the woman is seeing. Sometimes the woman may pretend she wants a male. She will tell you my baby is a male. Or she wants a female. Seeing the male, maybe she has about 3 or 4 boys. And this one too, she wanted a female and the baby has come male. She will tell you it's a female. So you make sure before you even weigh the baby, put the wristband, identification band on, make sure everything is said and done. Because this sometimes they can trick us. If you don't take care, you can end up with a huge problem. So identification of the sex is very, very important. So when we assess the baby and we identify any problem, we shouldn't hesitate. We should write, if it is at the outskirts, health center or CHIP compound, you refer and write everything that you did for the baby. Send the baby to the tertiary hospital where they have facilities to take care of this baby. So that is examination or assessment of the newborn. Especially with the cord, you already know they can apply so many things on which will bring out a lot of things. Cow dung, Pepsodent, salt, pests, and other things. We have been doing it, but we have to augment it more, talk to them so that it will continue to reduce the neonatal mortality.
Hello, madam.
Hello.
Hello, ma. Good evening.
Good evening.
Question. When you were doing this